Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the second session of this series, Palpation for Physical Therapists. Today we'll be discussing how to palpate the forearm and hand. So we'll start with the traditional topographical views and then we'll progress to the more detailed views. In this view we can see the right forearm and hand, and there are different structures that we can easily spot. If we start from this portion, we can clearly see the brachioradialis. Brachioradialis is the muscle that is attaching from the humerus and the radius, and it is an important flexor or contributor to the flexion of elbow, and it works in mid supinated position, and this makes most of the bulk on the radial aspect of the elbow. Then we can see these muscles. These are collectively called as the bellies of the extensor muscles. The lateral epicondyle of the humerus, it's a bony prominence. The Olecranon process, this is the process of the ulna, and it's again a bony prominence. Shaft of the ulna can be seen. Head of the ulna, it is a bit protruded. Extensor crease is very prominent in most of the subjects. Then we can clearly see the extensor digitorum tendons and the metacarpal phalangeal joints. The rest of the tendons and joints are not clearly visible. This is the palmar aspect or the anterior aspect of the right forearm and hand, and on the medial side you can see the bellies of the flexors of wrist and hand or fingers. So collectively these are common flexors, and on the lateral aspect there are the common extensors and the brachioradialis. The anterior aspect of lower portion of the arm can be seen. You can see the belly of the bicep, and the bicep brachii tendon can also be seen, the aponeurosis most probably. The medial epicondyle, similarly the flexor crease and the tendons of muscles. This Palmaris Longus is sometime present in a few people, and sometimes it's absent. So it is not present in all of the population. The thenar muscles making the thenar eminence, and the hypothenar muscles making the hypothenar eminence. In everyday speech, arm usually refers to the region between the shoulder and wrist. As an anatomical term, however, arm refers to the region between the shoulder and elbow. The portion between the elbow and wrist is called the forearm. So we are discussing the forearm and hand today. If we try to explore the skin and fascia, I mentioned earlier today in a meeting that the palmar aspect, the skin is really very sensitive and very soft, and it holds true most of the time that whole of this palmar aspect, this is very delicate and thin skin, and it has greatest mobility, whereas the dorsal aspect of the skin is less mobile and it is more thick. So this region where the therapist is grasping, basically this is the flexor region of the forearm and hand, and you can see that there is the greatest mobility in this direction, you can say in supination and pronation of the skin, or while we try to move into medial or lateral rotation. So the arrow shows the direction of the movement. So the skin is has the greatest mobility in this, whereas sometimes the skin also has the mobility in proximal and distal direction as well. If there is some sort of restriction, it means that there is some adherence between the fascia and fat and the muscles. Most of the time the scar tissue is very hard and is hypomobile. Now in this picture what we are looking at is when you try to extend the wrist, if you are grasping the tendons or the skin over the flexor surface, then what happens is as you passively extend the wrist, it becomes difficult for you to keep a hold on these tissues because they become taut and tight. But when you flex, they become readily available, they become more easy to grasp. Similarly, in neutral position, it is a bit easy. In flexion, it is most easy, and in extension, it is really very difficult to grasp the skin. Now we'll discuss the bones. There are two principal bones that make the forearm: the radius and the ulna. Radius being on the lateral side and ulna on the medial side in the anatomical position. For all starting positions, the anatomical position is considered to be the basic or resting or even sometimes referred to as the starting position. So we take the anatomical position as the neutral or normal position. So in anatomical position, the radius is towards the thumb and it is the lateral bone. The ulna is toward the medial side or towards the chest or tummy. So this is the medial bone. The anterior aspect of the forearm can be seen. Now it is very interesting to note that the ulna is more has more surface area on the proximal end, while the radius has more surface area on the distal end. So you can say that they are reciprocally shaped on top and below. So the ulna contributes mostly on the proximal area, whereas the radius contribute mostly on the distal area. So then we can see the carpal or the carpal bones. There are 8 carpals. We will discuss individual carpal bones after some slides. Then we can see the metacarpals, and finally we can see the phalanges. There are 2 phalanges in the thumb, and there are 3 phalanges in the rest of the fingers. The thumb is also considered to be one, or the first finger, second, third, fourth, and fifth. So this is the little finger considered to be fifth, the ring finger considered to be fourth, the middle finger considered to be third, and index finger considered to be second. The thumb is considered to be the first finger. And you can see the joints between the fingers, the thumb, the carpometacarpal joints, the metacarpophalangeal joints, and proximal and distal interphalangeal joints as well. Now we can see the highlighted bones forming the forearm. This is the anterior view and this is the posterior view. The posterior view tells you about the olecranon, which is visible on the dorsal or posterior aspect, but on the anterior view we cannot see it clearly because this is not present on the anterior side, and we can clearly see the head of the radius, which is present on the anterior side, and it is spotted very easily on the anterior side. These are the carpal bones. This is the distal radio ulnar joint, and then this is the wrist joint, sometimes referred to as radiocarpal joint. Now there are 2 rows of carpals. The first one is called the proximal row and second one is called the distal row. In the proximal row we can see the scaphoid, the lunate, and the triquetrum, and pisiform is the bone. It's a small bone and it sits on top of the triquetrum. Then we have trapezium, trapezoid, capitate, and hamate. So these are the 8 bones, and there's a mnemonic for it. She looks too pretty, try to catch her. This is the more detailed view of the bones. The radial head, the neck of the radius, the radial tuberosity, it is an attachment site for the biceps tendon, and then the radius shaft, and then the styloid process of the radius. The styloid process of the radius is larger as compared to the stylus process of the ulna, and this is the shaft of the ulna, and there is an interosseous membrane between these 2 bones, which is not palpable, but it separates the palmar aspect from the dorsal aspect. This is the posterior view, and again on the posterior view you can clearly see the olecranon process and some parts of the head of the radius, the radial tuberosity and shaft is clearly seen or visible in this view as well. There is also a tubercle called as the Lister's tubercle, which is a very important landmark when we are going to discuss the extensor tendons. They are divided into different compartments, and this is one very important bony landmark that needs to be palpated and it divides the tendon into different groups. We'll discuss in detail in later slides. So Lister's tubercle is present on the dorsal aspect, and it is very prominent, very easy to palpate, and it's a landmark that help you to understand the different compartments of the tendons. The styloid process, it helps you to identify between the radius and the carpal bones or the proximal row of carpals. So this is very important. The ulnar styloid process is very short and it's very little, and it does not usually help much, but still there is a lot of space, so it gives you space to explore the soft tissue area between the radiocarpal joint. If we talk about the bony landmarks, over here you can see the Olecranon process, which is fitted into the Olecranon fossa of the humerus. On the B, you can see the condyles. The radius is towards the lateral side, so this is the lateral epicondyle, this is the medial condyle or medial epicondyle. And then we have supracondylar ridges. These ridges, they are very important because you can make contact with these ridges and you can create some force by grasping these and pulling. In this picture, we are looking at the ulna. This is called the razor's edge because the ulna's side or the dorsal side of ulna is a bit sharp and it's easily palpable, and that is the reason it is called as the razor's edge, and it's become very superficial. So over here you can see the olecranon process. The shaft of the ulna can be seen, the head of the ulna, although very small, and it is present towards the distal end, and the styloid process of ulna. This is a posterior view or dorsal view, and this is called the pivot pos because the head of the radius, it makes a pivotal joint, and the movement of supination and pronation is mostly contributed by this joint, and there's some role or little role in the radiocapitular joint as well. So when you move from the lateral epicondyle distally, you will find the radial head. One important thing to remember is you can always ask your partner to supinate and pronate to find out the moving radial head. And there is also a clinical condition that I just remembered. There is a condition called as the pulled elbow. So this clinical condition is present in children, and whenever somebody is trying to pull a baby or a kid with a single arm, then there are chances that the radial head, it becomes dislocated from the annular ligament, and then this condition is called as the pulled elbow, or sometimes there are other names as well. So the lateral epicondyle, the head of the humerus, then the shaft of the humerus, it's bit uh, curved, and then the styloid process and the Lister's tubercle. The styloid process of radius is larger than the styloid process of ulna. Now, this is just for understanding of the names of the carpal bones, because these words are taken from Latin or from Greek. So, capitate stands for head shaped, like cap. It is originated from cap, and cap is weared on head. So, hamate is hook shape. Lunate, lunar means moon, so it is crescent shape, moon shape. Pisiform is small bone and it resembles P, so that is the reason it is called pisiform or P-shaped bone. Scaphoid is boat shaped. Trapezium is little table shaped. Trapezoid is again table shaped, and triquetrum is three cornered. So triquetrum having three corners. So this is very easy to palpate, the olecranon process and the olecranon fossa. It is very easy to palpate. Sometimes the fossa becomes very difficult because if the tricep muscles tendon is tight enough, it becomes hard to press into the olecranon fossa. But with some efforts, you can clearly feel the difference between the fossa and the bone. So the olecranon process is very prominent. When you flex your elbow, the olecranon process becomes more visible. and when you extend your elbow, it sinks into the olecranon fossa. So by asking your partner to flex and extend, you can find between the difference between the olecranon process and the olecranon fossa. Then the epicondyles, this is an ideal position to find out the epicondyles of the humerus, either medial or the lateral epicondyle. Uh, I recommend my students to explore the skin on the lateral and medial side of the arm over here, and you can come down from top and you can find these prominences on both sides, the medial and lateral side. These are the most prominent areas on this region, and even they are very palpable if the elbow is extended also. But when you flex your elbow, the muscles of the forearm, the flexors and extensors, they become really relaxed, and they give you more room or space to find out these structures. So from lateral to medial, the lateral epicondyle, the olecranon, and the medial epicondyle. The same can be seen over here. The lateral epicondyle, the medial epicondyle, and the olecranon process. Then you move proximally, and if you move proximally, you can find the supracondylar ridges. These are just the bony parts. They become funnel like, or they become triangular, just like an inverted triangle. So they they are moved towards inside or medial side. Shaft of the ulna can be palpated in mid supinated position. If your partner's hand is in mid supinated position, the bone itself lies very superficial to the skin, and it is very aligned in this position. You can easily palpate from the olecranon till the ulnar styloid. So you need to glide your fingers all the way from here to this point. Then the styloid of ulna can be found distally, and I told you earlier that this styloid is very little as compared to the styloid process of the radius, which is larger enough. So you can find out the styloid at the distal part, and there is more space. What you can do is you can passively or actively move the hand into ulnar and radial deviation. When you move your hand into the radial deviation, it gives more space to let you palpate the head of the ulna and the styloid process. So the alternating movement of radial and ulnar deviation can help you understand or differentiate between the styloid process and the carpals. So head of radius and shaft of the radius. The head of the radius is very proximal, and it is the starting point of the radius, and the ideal thing to do while trying to palpate the head of the radius is supination and pronation. So you ask your partner to supinate and pronate the hand, and then you can easily feel for the rotating head. In the mid supinated position, like the ulna was aligned and it was on the inferior border, the radius is on the superior border but not very proximal to the skin. It becomes a bit deeper structure in this position because this whole region is covered with the muscles, and especially the extensor muscles of wrist and forearm. The styloid process of the radius is larger. It is easily palpable. You slide your thumb and index finger from the shaft of the radius distally, just proximal to the wrist joint. You can clearly find the styloid process, very easy to palpate. And on the dorsal aspect, you find a prominence which is called the Lister's tubercle. So this is the dorsal aspect showing you the Lister's tubercle, and this is most commonly palpated with the thumb. So if you place your thumb just randomly onto the distal part of the radius, and and if you stay on this dorsal aspect, you can easily find the listus tubercle. Now the styloid processes of the radius and ulna serve an important jumping off points for locating the carpals, because there is a potential space present between the styloid process and the carpal. And over here you can see that there is more space available between the ulnar styloid as compared to the radial styloid. So this gives you more soft region to palpate, and this gives you more hard region to palpate. So but there is a trick, and that trick is to deviate the hand into the ulnar deviation and radial deviation. So you need to look at both processes and determine if the radial styloid process extends farther distally than the ulnar, and it should normally. So then explore just distal to the processes, noting how your fingers naturally sink into the tissue of the wrist, and this is the general location of the proximal row of the carpals. The first row or the proximal row of carpals is very easy to palpate. So this is the Palmar view, because there is just one thing to remember, that the pisiform is present on the Palmar aspect. It is very prominent on the Palmar aspect, and if you are a physical therapist, most of the techniques like mobilization or manipulation, or even sometime sliding the soft tissues, is with the help of pisiform. So the contact is also called as the pisiform contact. So pisiform is very prominent and very obvious bone in the palmar aspect. Then scaphoid, lunate, triquetrum, and pisiform. So scaphoid is just proximal to the first finger or the thumb, and it is towards the radial side. The lunate is the second bone, triquetrum is the third bone, and you can palpate these either in the palmar view or in the palmar aspect or in the dorsal aspect. Then the second row, you can see the trapezium, trapezoid, the capitate, and the hamate. The hook of hamate is also very important because it is toward the little finger. So when you palpate towards the hypothenar eminence, so this is the area that makes the hypothenar eminence. So if you palpate the hypothenar eminence deep to the muscles, you will find a prominence, and that will be the hook of the hamate. This is the dorsal view of the wrist. In the dorsal view, again you can see the scaphoid towards the radial side, the lunate in the middle, and the triquetrum lateral towards the ulna, and the pisiform, but it is not accessible from this side. The trapezium, trapezoid, capitate, and hamate are all accessible in this position. So here is another view, how different bones they fit into each other. And look at the small bone which is trapezoid, look at the small bone which is pisiform. So these two bones are relatively small as compared to the rest of the bone, the capitate and the scaphoid being the largest of all, and then trapezium, hamate, and lunate, and even triquetrum are almost the same size. So the pisiform can be palpated. If you are trying to palpate the pisiform, you need to move your palpating thumb and finger from the ulna, and from here if you jump to the styloid process of ulna, the first prominence that you will feel will be the pisiform, and pisiform is just distal to the flexor crease as well. So these are the lines in the skin, so this is called the flexor crease, and just distal to the flexor crease you can easily palpate the pisiform. It is the most easiest bone to palpate, and it is the most prominent bone to palpate. In this view, you can see the therapist trying to flex the wrist, and it also makes pisiform to sink, and when you extend, the pisiform is becoming more prominent. The triquetrum is palpable on the dorsal aspect, and when you move your thumb from the styloid process of ulna, the first bone that you come into contact with is the triquetrum. Again, the movement of radial deviation and ulnar deviation can help you understand the difference between the styloid process of ulna and the triquetrum. So, if the hand is radially deviated, then there will be more space, soft tissue between this area. There will be more soft space between the styloid process and the triquetrum. So, but if you deviate in ulnar deviation, then it becomes really very difficult to differentiate between the styloid process and the triquetrum. So it is always advisable to perform these movements repetitively just to find out the soft tissue border between these two regions, and then the first bone that you palpate distal to this soft tissue is the triquetrum. The pisiform is proximal to the hamate, but in the palmar view, you can only palpate the hook of the hamate. So just distal to the pisiform, you will find the hypothenar. This is the hypothenar region of the wrist, so or the palm. So you can easily palpate, but it is a bit deeper as compared to the pisiform. The pisiform is more prominent, and then if you press a bit deep, you can find the hook of the hamate. Again, this is the palmar view. The hook of hamate, once found, can lead you to the body of the hamate as well. This is very important tunnel. There is a carpal tunnel, and there is a condition called as carpal tunnel syndrome. Similarly, there is a condition called as uh, ulnar entrapment in the tunnel of Guyon, and that basically uh, limits your intrinsic muscles of hand, and sometimes it also has sensory motor supply, so sensory disturbance in the little finger and lateral part of the ring finger can also be present. So this pisiform and hook of hamate form a small channel which is called as the tunnel of Guyon. The ulnar nerve and artery passes through this canal under the shelter of its roof, and there is a ligament called as the piezohamate ligament that makes the roof of it. So piezohamate ligament attaches from this side to this side. If there is some shortening or there is some scarring, that may lead to compression neuropathy or neurovascular compression. The ulnar nerve is particularly vulnerable in the vicinity of the tunnel of Guyon to compression injuries. So activities such as repeated use of pneumatic jackhammer, it is a device that is used to drill or that is used to break any road, or leaning on handheld bars during long distance bicycling can put chronic pressure on the nerves. So if somebody is a cyclist, so they become more vulnerable to this sort of compression injuries. And you know for sure that carpal tunnel syndrome is very prevalent in people using their hands excessively, like typists, like pianists, like violinists, and uh, even the artists. Then the scaphoid and the navicular. Like the triquetrum was the first bone that you jumped from the styloid process of the ulna to, and in this case, if you move distally from the styloid process of radius, this is the first bone that you can palpate easily, and this is called the scaphoid, or also known as the navicular. And in this view, you can see that with the help of ulnar deviation, you can create a bit of space similar to the space created on the lateral. This is the lateral side on the medial side. So you create this soft tissue area or space. You first palpate the styloid process of radius, and then you palpate the soft tissue. And from that soft tissue, you jump over to the scaphoid. The trapezium is again distal to the scaphoid. So scaphoid is the first bone and the trapezium is the second bone, and it comes into contact with the base of the first metacarpal. So if you keep on moving the metacarpal of the first finger or thumb, let's say, so you can easily differentiate between the trapezium and the metacarpal. Again, this is the palmar view. In the palmar view, the scaphoid is a bit deep, so it is difficult to palpate in this region or in this position, but the trapezium is become it's very accessible also in this position, whereas it is also accessible in this position as well. And we mentioned earlier that the pisiform and the hook of Hamate are also very readily palpable in this palmar position. Now coming to the scaphoid and the trapezium, again keep on moving the thumb and you can feel the trapezium and the scaphoid, there will be a bump. If you keep on moving, then there will be a bump. With movements of the thumb, there can be a bump like this, and the bump, the higher part will be trapezium and the lower part will be the scaphoid. Then the lunate and capitate. So this is the Lister's tubercle, which is very prominent eminence on the dorsal aspect. So if you move your thumb or palpating hand from the Lister's tubercle to the middle shaft of the third metacarpal or towards the middle finger, you can find the lunate and the capitate. So the capitate comes in the way and the lunate is a bit bit medial to this. The lunate becomes very prominent, and in many clinical conditions, if there's a condition called as lunate subluxation. If there is some blow to the hand, or if a person falls on ground with flexed hand and the dorsal aspect strikes, so there are chances that the lunate becomes protruded, and this is the bone that becomes protruded. And normally when you flex your wrist, this is the bone that becomes more prominent. The metacarpals and the phalanges are very easily palpable because they are also long bone, but they have very small size. Although they are long bones, because they have all the features of the long bones, they have epiphysis, metaphysis, shaft. So So these are very easy to palpate. You can start from the first metacarpal, then you can jump to the second, third, fourth, and fifth, and these are relatively very easy to palpate. And what you can do is there is a position called as cupping of hand. So when you make a cup of your hand, then you can easily palpate or differentiate between the second, third, fourth, and fifth. And there is also an interosseous membrane between the second, third, fourth, and fifth metacarpal as well. The phalanges, they are distal to the metacarpals, and the joints, they become very important because these are the region which are called as knuckles. So they are very prominent and they are very accessible in any position. Luckily, on the palmar view, we have creases. We have small creases on the skin, and they are just superficial to the joints, and they can also act as a skill landmark to help you find out the phalanges or interphalangeal joints. And again, the movement is the trick. You can keep on moving unless or until you find the right bone and you find the right joint. In this picture, you're looking at the head of the second metacarpal being palpated, and it is very easy to palpate. And again, I must say, this is the easiest of the region to palpate. The muscles are very sometimes difficult to understand, sometimes very difficult to remember, but we will try to make them very easy to understandable. So in this view, although this is a bit inverted view and you don't see things very appropriately, but we can see the bicep, the bicipital aponeurosis can be seen, and then on the lateral side, there is the most superficial muscle is the brachioradialis, and if you come towards the medial side, you can see that this is the muscle which is flexor carpi ulnaris. If there is a muscle, this is the trick to remember these muscles. If there is a muscle, let's say flexor carpi ulnaris. So let's say this is a flexor, it is working or inserting on the carpal bones, and this is toward the ulnaris side, then there will always be a flexor carpi radialis. Okay, so there the muscles, they work in pair. So here you can see flexor carpi ulnaris. Over here you can see flexor carpi radialis. Palmaris longus, which is absent in some uh, patients or people. Then you can see the flexor digitorum, superficialis, and again the flexor pollicis longus, and the rest of the muscles not labeled here. There's also a very important muscle I forgot to remember is the pronator teres muscle. So the pronator teres muscle is a very important pronator, and it helps the pronator quadratus to turn the hand into pronation. In this picture, we are looking at the pronator teres, which is being cut over here, and the flexor digitorum superficialis, while flexor pollicis longus can also be seen. There is this thin band of soft tissue. This is called the flexor retinaculum, and it keeps all the tendon within the within the vicinity of carpal tunnel. So this is the region of the carpal tunnel. The flexor retinaculum makes the roof of the carpal tunnel. Over here you can see different muscles are cut, like flexor digitorum superficialis has been cut. The flexor pollicis longus lies deep to it, and the flexor digitorum profundus also lies deep to it. And again the flexor retinaculum. There are 8 tendons collectively that passes through the carpal tunnel. In this view, there are different muscles that can be seen. This is the lateral view. Very important muscle is the extensor digitorum, the brachioradialis, and the extensor carpi radialis brevis. And there is another muscle which is called as the extensor carpi radialis longus. Then these are the muscles for the thumb, and they are making the anatomical snuff box. The extensor pollicis brevis, abductor pollicis longus, and extensor pollicis longus. The names of the forearm muscles can be a mouthful. Nevertheless, these same muscles, the names can be very helpful when it comes to understanding a muscle's function, location, and more. For example, I told earlier extensor carpi radialis longus. So, what does it reveal? It reveals that it is an extensor. So, it extends. This also indicates that there is a flexor carpi radialis. Okay. So, carpi means it extends the carpal bones or the wrist joint. This indicates there is also a different muscle that moves the digits, extensor digitorum, and it runs along the radial side of the forearm. This indicates that there is also an extensor carpi ulnaris on the ulnar side. So if there is a longus, it means there must also be a brevis. So extensor carpi radialis brevis. So if you remember one muscle, you know with this muscle you can at least get the names of 4 to 5 muscles. In this view, we can see the brachioradialis, the extensor carpi radialis longus, the extensor carpi radialis brevis, extensor digitorum, abductor pollicis longus. All these muscles are sometimes very prominent if the patient is habitual of working with the muscles of forearm. Again, a few muscles are cut. The superficial muscles are cut just to show you the deep muscles. Here you can see the supinator. It assists the bicep and in the movement of supination. And then you can also see the muscles of the thumb. These are the abductor pollicis longus, extensor pollicis brevis, and extensor brevis and longus. These are the muscles that work collectively in the elbow region to flex and to extend. You can see the flexors. There are a lot of muscles that can contribute in flexion, and flexion is the strongest movement as compared to extension. Extension is a bit weak movement, and this is partially because there are just two muscles that are working. This is a small muscle. It also is present in some patients or people, and it is also absent in some. So the main contributor is the tricep. The supination mostly done. Strong supinator is the bicep brachii, then the supinator and the brachioradialis. It also assists sometimes. The pronator, there are pronator teres, pronator quadratus, and the brachioradialis it assists. In the wrist, there are muscles that work to perform the movement of extension and flexion, almost similar muscles. Extensor carpi radialis, so there will be flexor carpi radialis, extensor carpi radialis brevis. So again, there will be flexor carpi ulnaris. There is extensor carpi ulnaris, extensor digitorum, flexor digitorum, superficialis, profundus, and extensor indicis. But there is no flexor indicis. So these are the muscle. For abduction, all these muscles are working together, and for adduction, there are just extensor carpi ulnaris and flexor carpi ulnaris. It is very interesting to know that most of the muscles of the forearm, they have bellies very short, and they have tendons very long, because they work on the fingers. Uh, Especially, there is a flexor called the flexor digitorum profundus, and there is a flexor called as the flexor digitorum superficialis. So they insert onto the proximal and distal phalanxes. This movement is very important clinically, because if you ask your patient or partner to perform the opposition and combine it with wrist flexion, if the patient or the person has the palmaris longus, the tendon of the palmaris longus will become very prominent. And if it is not found, it means that the palmaris longus is absent. Brachialis is a large muscle. It helps in elbow flexion. Here you can see it is lateral to the bicep brachii. Brachioradialis, it assists again in the flexion of elbow, but in the mid supinated position. So this is an important muscle when you are turning a door handle or a screwdriver, bringing a beer stein up to your mouth, whisking cream in a bowl, or hoisting a toddler out of the crib. In the mid supinated position, the brachioradialis is very prominent, and it is the superficial most muscle. What you can do is you can ask your partner or patient to perform the resisted radial deviation or isometric contraction towards radial deviation, so it makes the brachioradialis more palpable and prominent. The bridge between the flexors and extensors of the forearm muscle. This is the brachioradialis that makes the bridge between the flexors of forearm and extensors of the forearm. The extensors can be seen: extensor carpi radialis longus, brevis, and extensor carpi ulnaris, and extensor digitorum. If you place your fingers just like this, so Underneath your index finger will be extensor carpi radialis longus and brevis. Under your middle finger there will be flexor digitorum, and under your ring finger there will be extensor carpi ulnaris. Common extensor origin. This is a very important clinical site because there is a condition called the lateral epicondylitis or the tennis elbow. In this condition, there is inflammation or micro trauma or strain to the common extensor tendon, and this is the site. It is very proximal, or sometimes it is just superficial to the lateral epicondyle. Here you can see the extensor digitorum. It is being inserted onto the lateral epicondyle, and these are the tendons of extensor digitorum. They becomes very prominent if you make your hand into a claw shaped hand. And conius is a small muscle. It is sometimes absent, and this muscle is present on the lateral side and on the dorsal aspect. Extensor indicis, the small muscle. This muscle is especially for the index finger, and you can also see the prominent tendon of extensor indicis. Now, flexors of the wrist and fingers. Just below the brachioradialis, if you place your hand like this, then the topmost muscle will be the pronator teres, and this is the muscle under which the median nerve passes. Then, and there is a syndrome also called as the pronator teres syndrome. So that is just because of the tightness of this muscle. The flexor carpi radialis, the palmaris longus, and flexor carpi ulnaris. And again, there is a very important clinical condition that arises from this part, and that is called as the medial epicondylitis of the tennis elbow. It is very similar to the golfer's elbow, but just that the location is different. It is on the medial side, and the golfer's elbow, the tennis elbow is on the lateral side. Here again you can see the flexor carpi radialis, palmaris longus, and flexor carpi ulnaris, and rest of the flexors. This is another detailed view of the flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. So collectively these muscles make the bulk on the medial side of your forearm. Now this is flexor digitorum superficialis and the flexor digitorum profundus. The superficialis is on top and profundus is on the deep. And again you can see that there is a fine crease, and just below this crease you can find the flexor digitorum superficialis and profundus. Again you can palpate the common flexor tendons or the origin of the common flexors. It is just distal to the medial epicondyle. The palmaris longus, you can resist the flexion of the wrist, and it helps you differentiate between the palmaris longus and flexor carpi radialis and flexor carpi ulnaris. In flexion, if you perform ulnar and radial deviation, the flexor carpi radialis is towards the lateral side, and the flexor carpi ulnaris is towards the medial side, and in between these two is sandwiched the palmaris longus. You can also strum across the flexor carpi ulnaris. Flexor digitorum superficialis becomes very active when you perform this opposition movement. Then these are the small muscles of hand and thumb. Uh, these are the muscles that are making hypothenar eminence, and these are the muscles that are making thenar eminence. So there are Epiductor pollicis brevis, then Flexor pollicis brevis, the flexor. Then you have Epiductor digiti minimi, and all the interosseous muscles and lumbrical muscles are deep to these structures. This is again palmar view, and you can see the lumbricals and the opponents digiti minimi. Collectively, these muscles are making the bulk of the hand, and it is almost not advisable to try to palpate these individual muscles because these are very small and fine muscles. These are the long muscles of the thumb, the Epiductor pollicis longus, Extensor pollicis longus, and Extensor pollicis brevis. And I told earlier that anatomical snuff box is a very important landmark to find out these tendons. Here you can see this part, this red part is the anatomical snuff box, and on top of it is the Extensor pollicis longus tendon, whereas on bottom you can find the Extensor pollicis brevis and Abductor pollicis longus tendons. You can make this area more visible by resisting the thumb's extension. If you want to palpate the bellies of these muscles, you can ask your partner to make circles with your thumb, like clockwise or counterclockwise, and just proximal to the extensor retinaculum, you can find the bellies of these muscles. Then the short muscles, they are making the thenar eminence, especially the Epiductor pollicis brevis and Flexor pollicis brevis. There is also opponens pollicis and Adductor pollicis. So if you want to test the Adductor pollicis, you can again ask your partner to perform the opposition movement, and then you can feel the tensing muscle. This will be the most superficial muscle, the Adductor pollicis. Then ulnar nerve, like we mentioned in the previous lecture, is called the funny bone. So this is very important clinical landmark, and that landmark is between the medial epicondyle and the olecranon. There is this space through which the ulnar nerve passes. There is also a fat pad that protects the ulnar nerve, but this is the site where the ulnar nerve is. It is quite difficult to palpate the nerve because it is not a very major nerve, just like sciatic nerve. Sciatic nerve is a very major nerve, so if it becomes superficial at some part, it becomes very readily palpable. But this is not the case with the ulnar nerve because the ulnar nerve is very small as compared to the sciatic nerve, so it becomes very hard to palpate the ulnar nerve unless or until it is inflamed. The bursa normally is very thin film. It's about 1 millimeter or less than 1 millimeter thick. So it is again next to impossible to palpate it easily. But if you see swelling, just superficial to the olecranon, you need to understand that this is the Olecranon Bursa that is being inflamed, and that condition is called as olecranon bursitis. This is the reference book. Now we'll take questions and answers. Thank you very much for listening and staying silent.